We need to start posting something in the beginning of these that we're going to scare the hell out of people uh, with with the updates about what's going on in the world. Hi, everybody. This is Chris, and with me, we have a special internal conversation session, a Hotwash, which I think you're familiar with. Is just a short session where we're touching on miscellaneous topics. Al,
Hey
are
guys, this
you
is Al.
ready?
Yep, and
Yep.
I am ready to go. It's time for another hot wash. We need to get rolling.
Hey, yeah, and this is Mike. Well, there's lots of stuff we can talk about, guys. There's just all kinds of stuff going on in the world right now, and boy, where do you even start?
Why don't we start? If you guys are okay, let's start with something that Mike has really got some connections and history with, and that's just the world of infectious diseases and special pathogens. Mike, what's going on?
Yeah, not to keep beating this one into the ground, but I tell you, folks, I mean, I've been on kind of a crusade the last how many months of trying to I guess, foster more attention to our preparedness as healthcare institutions for the next outbreak, the next pandemic, or what we might call a special pathogens. And so, or a special pathogen. And keep in mind what a special pathogen is. It's something generally considered to be a novel or new or existing infectious disease that has been proven to be or is suspected to be um, fairly deadly with a fairly high mortality rate and morbidity rate with human infection. That there generally is not a cure for it, there's not a treatment for it, and there's generally not a vaccine, either because of its novel nature, that it's something that's emerging, or it's something that's been around for a while and it's very difficult to come up with effective treatments or any kind of vaccine. So that's what a special pathogen is. And the thing we've been talking about is what's going to be the next, like, COVID-19. Will there be another one? Sure, there will. Yeah, there's going to be another one. Anybody who thinks there's not is kidding themselves. And so, what we're concerned about is something that would be novel, something emerging that is usually transmitted via airborne. It's airborne nature, and that gets to the most people in the shortest period of time. And so, yeah, that's what we're most concerned about. Some sort of emerging respiratory pathogen. But we also can't really dismiss some of the stuff that's out there, that isn't respiratory, such as contact stuff like a viral hemorrhagic fever. And so, the case that we had in our state here in Iowa back in October, November of last year was a viral hemorrhagic fever called Lassa fever, right? And we've talked about this on this podcast before. Very novel to come into this country. It was only the ninth case in the past 50 years, but it illustrates the point that you just never know. And whether you're ready for it or not, stuff like that's going to show up. Now, where are you going to have it? The people in the big cities think they're going to have it. But this was a case that showed up in a town of 15, 20,000 people, and the case walked into an urgent care, a doc in the box, and then ended up in a level 4 hospital ER and then got admitted. And so you just never know. They're not just going to show up into the big centers or the ones that are really funded by the U.S. government. There's only 13 of them out there right now funded by the U.S. government to be prepared and to serve each FEMA or HHS region. And it's a fallacy that people think they're going to just go there. Heck no. Somebody's going to just walk into wherever they can if they're not feeling well. And most of the time, they're not going to know what they've got. So it behooves everybody. And that's why there's Joint Commission and DMV requirements now that there is a certain level of special pathogen preparedness at every healthcare institution. I don't care if you're level 1, 2, 3, 4, or you're a clinic, or something like that, you have to have some kind of preparedness planning for that kind of thing. And so the downside is funding, right, guys? I mean, how do you prepare for something like that? There's no federal funding for anybody other than the 13 level 1 centers or regional special pathogen treatment centers. They're called RESPECs that are out there in our country. The level 2s, like what ours was, that we ended up with this type of case. The level 3 test centers, the level 4 is everybody else. Nobody gets any kind of special funding other than the level 1s. That's a problem. And I've been talking about that for a while. There's almost 6,000, there's upwards of 6,000 hospitals in this country. Only 13 get funding for that kind of thing. And that's a real problem. And so that's why we're trying to say to EMs out there in the healthcare world, put this and make sure it's on your HVA, your hazard vulnerability analysis, somewhere on your HVA. Now, is it going to make the top 5? I don't know. Doubtful, right? Could it be in the top 10? Is it something that you would exercise or drill on a fairly regular basis, even on an annual basis? I don't know. How many people are actually even doing that? They got other things. And so I know we'll talk about other things, like you got to worry about gun violence, right? And that kind of stuff. That stuff's been pretty high on our radar for a while, whether it occurs in our facilities or you're the receiving institution for something to happen someplace else. But I just want to make sure that we're not losing sight of that infectious disease thing, because it's something that we got to be concerned about. And, I'll be honest with you guys. Right now, we don't get a lot of surveillance out there and a lot of information sharing from the federal level down to us. And so we're on our own. We got to figure this stuff out on our own. And even all the RESPECs out there we talked about, I've been to several recently over the last few months, and we've all made a pact. Hey, we got to talk to each other. If somebody knows somebody somewhere that learns about something somewhere happening in the world, that come fly and get on an airplane and come back to the U.S., tell everybody, all the regions need to be talking to each other and networking to kind of take up the slack of where we used to get regular bulletins and sharing of information. And so just everybody right now, I don't know if you know about this, but there is another situation in the Democratic Republic of the Congo, DRC. Shouldn't surprise everybody. This is only the 16th outbreak of a viral hemorrhagic fever that we've known about since they started back in 1975, right? So this is the 16th Ebola outbreak in the DRC since the virus was first discovered back in 1976. And so as of the September 17th, there were a known 48 confirmed cases. A few were probable, but there were 48 confirmed cases. And this is the scary part, 31 deaths. That's a case fatality rate that nobody wants to see, right? So 31 deaths out of 41 people, and that included 4 healthcare workers. So this stuff is out there. Now, what's the threat to the rest of the continent of Africa, and what's the threat of it ever coming back here to the U.S.? Hopefully very low, right? Ebola is not one of those ones that is as exportable as what we experienced here in our state back in the fall of last year. Lassa fever is probably the most exportable viral hemorrhagic fever type in the world in terms of it being able to jump on an airplane and go someplace else. It's probably number one. And the reason is that it's harder to diagnose, and it's harder for people to know if they've got itってthe wide range of Lassa fever's presentation. You can be asymptomatic with it, or you can be full fulminating case lying and languishing in an ICU. But only 1% has got a case is known to be fatality related. Whereas we now know Ebola is a different animal. And the other reason is Ebola, one virin. That's all it takes. You get one little teeny tiny virus in your body. That's all it takes to make you sick. And it's not like you're going to be asymptomatic with Ebola. Whereas it's about 15 times more virus particles, about 15 virin that need to get into your body to make you susceptible to Lassa fever. And even then, you may not even know it. You may be asymptomatic and never know you had it. Or you could just have a common cold kind of thing.
So,
or
Mike, do
flu.
we need to start posting something at the beginning of these that we're going to scare the hell out of people uh, with the updates about what's going on in the world? Can I walk you back though from the destination management, so to speak, those 13 hospitals that the buck stops here, the patient's here, we've got to deal with it, to the frontline hospitals where it's high consequence infectious diseases. It could be measles, right?
Sure.
Highly, highly contagious. Or it could
Much
be
more.
one of these, right?
Yeah.
And the diagnosis may not occur, but the method of handling, where you've got people with coughs and fevers, and we get into the season where there's cold and flu, and they start to, by sheer volume, let things slip. it I'm taking what you're saying and wondering if, without a lot of funding but just a lot of common sense, that a good time to do some drills and some reviews of high consequence infectious diseases, um, or special pathogens, would be here in the fall coming up, right before
Totally
flu
agree.
season, right?
Totally agree.
And you don't have to talk necessarily about the specific pathogen. I mean, you should, but the process should be standardized, where it's what's the acronym that you guys
Yeah.
use?
So everybody, and this is absolutely concrete. It should be like the 10 commandments. This is the 11th one for hospitals or clinics. The 3 I's. The 3 I's. Identify, isolate, and inform. There should be no healthcare institution, clinic, hospital, doc in the box. I don't care what you've got. Any patient walking into your facility seeking care, the first thing that happens is you inquire, hey, have you got a fever? Have you got a cough? Have you been anywhere outside the country? And, any signs and symptoms that you're ill like that, immediately that gets you on the I part, the identify, right? So your medical records system, like whether you have Epic or whatever you got, it should be automatic all year round. 365 days a year, you are screening everybody walking into your system, no matter where they access it, so that you can quickly identify them. And once you identify them, then you have to do the next thing, which that's where the EMs and the infection control people come together and work. That where are you going to put them? You got to isolate them. Do you have isolation capability in your facility, in your clinic, in your ER, whatever? Do you have negative air pressure capability? If you don't, there are tools out there that can be used to convert any hospital room or ER room into a safer negative pressure environment. And that's something worth looking into as an EM or as in your infection control nurses. What are we going to do with that patient to kind of keep our staff and everybody else safe? Because we now have to care for this patient. You bring them into a regular ER, they could be spreading that stuff not only to your staff, but to the other patients. Or do you put them out in your waiting room and go see them in order the way you receive them? Now they're crapping up everybody in your waiting room. So I mean, all of those things. This is the perfect time of year to look at your preparedness for things simply like cold, flu. It'll help with measles, like you say, which is, God, 15 times more worse. And then right down to your viral hemorrhagic fever case that you hope never walks into your country. If you're doing the 3 I's, hopefully you've got your bases covered from the get-go as the first receiving facility.
And I'd like to jump in here too, because you guys, I use as sounding boards a lot, and I have over the past, as we were all emergency preparedness coordinators at our hospitals and stuff, reminding everybody that's listening, you don't have to be an expert in the field in order to get involved and be a part of. Here I'm a non-clinical person. Mike and Chris, you're both former paramedics, and you've got that clinical background, you've got that medical knowledge type of stuff, and Mike, when you talk about it, people think, oh man, I don't know. He's way above me. That's where we're trying to get with everybody. Get with the people who can give you the pieces of information that you don't have. Now I've got logistical and things, information that you guys have talked to me about before. We all have our expertise. We all have our areas we focused on. So for those preparedness people out there who say, oh man, that's way above me, don't let it be. Don't let it get away from you. Take the information, talk to the people in your area that, your infection prevention people, others, and take a look at those three I's: the identify and isolate and inform. And Mike, you mentioned something also that you go, well, how do I get that into the drills and exercises which I'm involved in as a preparedness person? You mentioned HVAs, a hazard vulnerability assessment or analysis, and I used to, and I've talked to other people. I used to manipulate those a little bit because I said, you know what? If I want our focus this year to take on that, I will make sure those numbers work out so the HVA shows it as a top 5. And that's not playing magic with numbers. It's just identifying. So when the executives go, why are we doing this? Well, because we are not prepared here and we are not prepared there. And you can show them the numbers rather than just blowing it off and thinking, oh, it'll never happen. Well, we didn't think COVID was ever going to happen. We didn't think, highly infectious disease. Who talked about that besides the IP people long ago? Nobody. Now everybody's aware of it. And I think that's the important part that Mike, you're talking about, and Chris, you're kind of wrapping around is don't any of you listening, whether you're a preparedness person or whether you're just listening to the podcast, get involved with some of that information and get with the people who fill your circle up with the knowledge that you don't have.
Yeah, I would just add to that, Al, that I mean, even though we use the word special and we talk about HVA and ranked importance, this is just a basic risk that's consistently out there for healthcare. Yep. And so I think it's an annual review. This isn't necessarily an exercise. It could certainly be an exercise. It could be a drill. I think it's, as much as anything, a checklist where you're going through and reviewing any construction changes or impacts to your HVAC, as Mike said, so your air handling system, to your different units and your staff. There's such staff turnover. Mm-hmm. What's the education and the updates have been. But I think this can be also kind of tested with somebody, then, and your infection prevention people can help recruit and brief somebody to basically walk into an ER.
Secret shopper.
Right. Kind of the secret shopper where they're emulating some kind of infectious disease scenario. It doesn't have to be exotic. Measles, hell, it could be measles, right? And test the system for its ability to respond. And quite frankly, maybe that's a semi-annual thing too, right? Because the seasonality that we saw in the past changed a little bit during COVID. And I think we're seeing summer outbreaks and things that end up maybe catching people off guard with an earlier fall. So this doesn't require huge amount of resources at the front line. The frontline people need to make sure you have a process and you understand those basic, the 3 I's, but then also how do you connect? And how's that going to work when one of those tertiary care facilities is going to want the patient transported? And that's where you bring in EMS and the other partners during COVID and just review. And, if COVID is a word that nobody's comfortable with, you can put in Ebola, you can put in the measles, you can put in something imaginary, but it needs to be reviewed annually. And before you review it, do your homework, find out what the updates are, find the resources. Several times in this podcast, we've talked to people that provide resources. Mike, NETEC, right? NETEC's got a bunch of free stuff for frontline hospitals and everything, right?
Yeah, so, absolutely. Yeah, which will help with any of these things, right? So, NETEC.org, NETEC.org has got free checklists, free drills and exercises. They'll come on site. They'll help you draft it. I mean, they've got EMS committee that could integrate your EMS providers in terms of transport if they need to move to a higher level. I mean, they've got everything and it's all free. Why wouldn't an EM take advantage of all the free stuff that basically do the work for you as far as drafting and writing drills and exercises on this stuff? Absolutely take advantage of it, man.
And then I would add that check in with your healthcare coalition to see if plans have changed, if contacts have changed, and you've updated those. And then we also have our EMs, and they were the connectors for strategic stockpiles. Those stockpiles have changed fundamentally, both in terms of content and perhaps in the way that you access them. So again, things to review kind of comprehensively. And since it's really virtually every facility's responsibility, work with your partners, work with other folks, and say
partner
what
piece,
works and what doesn't.
absolutely. The partner piece is so important that I've seen a lot of people miss out on. They try to think of themselves as an island, and boy, you can't be that solo person out there, or that silo, if you will. You've got to work with your partners and get them involved, and that's how you're going to make your community, your hospital, your whatever you're dealing with company stronger. Absolutely.
And that's true, but may always keep in the back of your mind, the cavalry may not be out there ready to ride in and help you. And that's something that needs to be stressed. It's like, like you and your logistics and stockpiling, background, Al, that the bottom line is every healthcare facility has to have a certain amount of preparedness and autonomy when it comes to things like PPE, right?
Yeah.
Because the government's not going to come riding in with truckloads of PPE to help you out this fall.
And if they do, they might be expired.
Yeah, and they probably will be.
Yeah.
If there's anything like that, and to count on others to come and help you. Now, if you're in a big system, like, we got some pretty big systems within our state that maybe there's a regional stockpile that feeds all the facilities within that given healthcare system. Great. Awesome. But there's a lot of hospitals out there in our area.
Yeah.
They're on their own, man.
Yeah.
Yeah.
And so they're going to knock on the door of EMA and say, hey, EMA, what can you do to help me? That
or
kind
public
of thing.
health, public health, which is also strange.
Right.
So-
Public health could
so-
help, but it's like, don't count on it. There's got to be some commitment at the local level.
Yeah.
That you may be on your own for a while, at least.
So to help us understand, I want to pivot for a second, and maybe Al can help us with this, but let's talk about how well an EM might understand what their roles and responsibilities are. In some cases, and I think all three of our cases, we left organizations before the positions were really filled. Our respective positions were filled. So if you're a newer EM, or you're one that hasn't gone in this area, how do you learn more about the role of being a hospital emergency manager or emergency preparedness professional, Al?
I would say back to what we were talking about before, and we'll bring up, there's organizations out there that you can become a part of. We've talked before about our hospital Alliance for Preparedness in Iowa, our HAPPY group, that we just come together as a group. Now that's isolated to Iowa, a little bit different for those listening outside the state of Iowa. They go, well, you've got other organizations out there that you can tap into. AHEP, the Association of Hospital Emergency Preparedness Partners.
Healthcare.
Healthcare. There's other organizations out there, and there's some hospitals out there in your surrounding area that are resistant to helping because you're competing. But I've seen more so in terms of the emergency preparedness roles. They're also there to help and reach out, and people need to be aggressive and active enough to go out and do that and not wait for somebody to come to them.
But before you do that, Al, are there certifications? Is there training that people can take to learn the basics of the roles specific to hospital emergency management?
And we've all talked and looked, and all of us have the CHECK certification, the Certified Hospital Emergency Preparedness. I think, isn't that right, Chris? CHECK.
I think it may have also
Hospital
changed to healthcare.
Healthcare coordinator.
Yeah, healthcare emergency coordinator.
And that was one of those ones where it gave you all the basics. And also the key part in there. Mike. I came out to Mike's area and met another guy by the name of Chris Perrin. That's the first place I met him. but it was not only the information from that certification and the getting together, which it lets you network, lets you do a lot of stuff in there now. So we're networking here. I don't like it as much because when you and I and Mike get together, Chris, we do a lot better, but we've learned to do things over virtual, over Zoom and Teams and everything like that. And you just have to embrace that and go on with it. I know mentioned about Czech, and then I mentioned AHEP. They have a really, really robust certification program, but you need to be in the business a little while to maybe get into that. Now they have 3 stages. And what I'd like to do in the future podcast is maybe bring on Christy and Keith from AHEP and talk about that certification program specifically for people who are interested in it. Because I think it's probably one of the top-notch certification programs people can go through.
It's a newer one too, right? It's
Yep.
just in recent years, and it was peer built, and I think they looked at science and evidence based practices as they put it together, and they have cohort groups and study materials, and yeah, that's maybe a little bit bigger lift, but more comprehensive, and as you said, kind of a staged.
And it helps you not eat the whole elephant at once. You know, you go to some of these certifications and in 2 or 3 days, they pack a lot of information to you and you hope you come away and remember 10 or 15 or 20% of it. They've got a staged 3-level piece where you build and become competent in the first area. Now you step into the second area and start your competency levels on there. So there's some really cool stuff out there. And again, I'm not just promoting those 2. There are probably many others that I'm not aware of because I've seen others with certifications behind their name. They're all good. They all get you some level of information and the networking with the other people, because as we're talking with our partners, it just helps, again, fill the gaps.
You know,
Right.
and what's
So-
interesting to me
Yeah.
nowadays too is that people filling level of positions like we left, particularly at my area, and I'm not so much sure how that works with you guys, but they were looking for people with master's degrees in emergency management. Okay, that's all well and good. Great. You know, I'm all for that kind of stuff. I did not have a master's degree in emergency management. Okay, I didn't. I was the classic picture here. You're going to do this. You're going to be the emergency manager for this healthcare system. I go, what's that? And they go, oh, you'll figure it out. That's not the way it ought to be done. If somebody's got a master's degree in emergency management, it's generally not in healthcare related or focused, right? There might be a little healthcare in there. I don't know. But most of the time, those are heading for more, you know, secular kind of things like, you know, county or state or even federal government type of emergency management, or maybe private industry, but not necessarily healthcare. So the things Al, you and Chris have been talking about are very healthcare related. And so even somebody with a master's degree in emergency management is still going to need that kind of training.
Very good point.
Because they don't get enough of it, my guess, in their master's program to fill in those gaps.
Yeah.
And then I would, you know, again, turn to Mike and say, you know, there's the kind of that foundational training, but one of the core pieces of networking is being able to reach out to people that have more extensive resources. And as somebody that worked at a tertiary care facility, how did you receive calls? I mean, how reluctant were you to take calls from people that say was a new emergency manager at a hospital that's saying, hey, you know, you're the Ebola facility for our area. What is it I need to know? I mean, were you slamming the door, putting them off, or were you? Yeah.
I can remember when I was assigned. I wasn't hired. I didn't apply for my position. They said, you're going to do this because we've never had anybody in that position. I was like, okay. But I was also made very clear by my boss that because we're a state owned and operated institution, he goes, the answer to those kind of questions is yes, I'm here to help you. We are intended to be a resource. All right. Now, would that be different in a different type of environment? I don't know. You guys have to tell me that because you come from private entities. I came from a state-owned and operated entity. So I was basically instructed and always conditioned, no matter what role I had, is that you are to be a resource. You are to help others throughout the area. And that's your mission. You don't say no. You say, I'll try to help you or get you somebody who can.
I think in most cases, I see the same thing, Mike, and in the organization that I belong to, you know, it merged with another larger organization, and all of a sudden we were asked to help other facilities at other locations. And you're right. The answer was always yes, sure. We'll fit it in somehow, and we'll share policies and we'll share procedures and try to find best practices. Best practices for one site might not be a best practice for another site, but you don't start with a blank sheet of paper. And I think that's a very good point that you just need to use those resources that are out there. And if you are with a organization that has several sites, um, yeah, stretch out. I know it's happening.
Hey guys, it's a hot wash, so we have to be self-limiting. Maybe two more things that we can do here in the some remaining time. One is Al, I think you had a public service announcement or some insight to share, and this is we're winding down on Emergency Preparedness Month, so maybe you could spend a minute or two on that, and then
Yep.
at the end, let's touch bases. If you're watching or listening to this podcast before mid-November, Mike is going to be involved in a program, and maybe Mike, you can share a little bit of details about that, and we can, again, it's a no cost educational sort of thing. So, Al.
Well, yeah. One thing I learned recently, well, I was golfing because now I'm retired, golfing with some buddies of mine. I talked about the recreational stuff and preparedness to keep yourself healthy and fit in the area. And I was talking about, hey, maybe my wife and I are going to move from the pedal bicycle to maybe an e-bike. And the point I learned, which is kind of interesting, was the insurance guy said, well, now there's a difference between a pedal assist bike and a pedal assist bike that has a throttle on it. And I said, no, tell me about it. And very quickly, he just summarized and said, your homeowner's insurance covers you for riding a bicycle, even though it's pedal assisted. But once you put a throttle on it, you have a motorcycle, and you better cover that with motorcycle insurance, because otherwise you could be left out in the dark. Little public service announcement for those people who are moving into the e-bike arena. Not to say that the throttle bike is bad. Be aware and make sure that when you go out, because Mike and I were talking, there have been some accidents because people, on e-bikes and other things. Just make sure you're covered and make sure you're aware of what you're getting into.
Yeah, man, because I was thinking of our ER people.
Oh,
Our
yeah.
ERs are like, oh, great. These retired people are playing pickleball. They're riding e-bikes because they can't get up hills on their own anymore and all this crap. And it's like, okay, these are our age group as retirees have had a, 30, 40% increase in ER visits because of these activities that we're trying to stay healthy
Wow.
with. And we end up in a trauma situation. How sad is that, man?
Yeah.
Mike, tell us about November and something you're being involved with.
Well, I mean, and the other thing we need to start looking at more too, guys, is this gun violence thing. I want to bring that up maybe next time at our next podcast. We really need to look at the scourge of gun violence and how us as EMs from the healthcare world need to really be on top of that as far as preparedness of our facilities. Either it occurs in our facilities or we're the recipients of it occurring someplace else. This is a scourge in our country. And I think we need to spend some time on that. And so anyway, so, there is a free education coming up in November that we're going to do with our partners at Nebraska Medicine, University of Nebraska, which is the Region 7 Level 1 respect. And we're going to talk about this viral hemorrhagic fever thing that occurred here in our state, which affected 3 different states. 170 people were exposed. 162 of them were healthcare workers. And so, we want to talk about how the country is preparing for something like this. where we need to make improvements. There needs to be more funding. There needs to be more support to develop this infrastructure. We just want to raise national awareness to see if we can't get more federal support for the National Special Pathogen System of Care. It's like a trauma system, but it has nowhere near the support that the trauma care system has, or even the burn care. So, we want to bring this around. So it's coming up in mid-November, and we'll be getting more information out when it happens.
I was going to say that the link or anything of the information hasn't been released yet. Mike, you're going to coordinate that. Maybe, for those listeners, if you're interested, Mike will give you our contact information for Readiness Rewired, and you can reach out to us. And as soon as that's available, we can get that to you, because I've heard the presentation before. Chris, you've heard it, and it's eye-opening and phenomenal.
Yeah, you might want to post that information with this episode too.
I will indeed.
For the intro. That's a good idea. All right. Anything else, guys, for the good of the order? We've got plenty for gun violence. I think vehicle or just violence is, civil violence and preparing for it apolitically. We're not talking about a political, it may be motivated by political sentiment, but we're talking about just a generic response, a safe response, and a good response towards violence of any
it's
sort.
The world we live in, no matter what the origin. And I know with our facility, we got armed officers now because of this situation that we're dealing with in our country. We have to protect our facilities, our staff, and our patients. And so it's a thing, we as EMs, it's a thing. We got to be ready. We got to work together to get ourselves prepared for it.
And I want to suggest we have another podcast coming up here while we're kind of give the listeners something to be watching for. We need to do something on human trafficking, because that's an ongoing thing, and we've got some great contacts within the three of us that we can get some more human trafficking information out there, because the more you hear about that and the more you understand, our emergency departments are a prime area for spotting and helping those areas. So let's do something on that in the future. Hopefully people will be interested.
All right. Thanks, guys.
All right. Well, folks, you know the drill. We'd love to see you come back. If you need to get a hold of us, we're available at readiness.rewired@gmail.com. Click that link up there. Click the bell to make sure you know when we post another video. Give us a thumbs up if you like what we're doing. Thumbs down if you think we suck. But we want to hear from you. We want you to come back and make sure you tune in. Take care and be safe out there.